Hello, my name is Mary De Silva, and today I'll be taking you through an introduction to theory of change for designing and evaluating complex interventions. There's three parts to this talk, and there's three separate files for you to go through, so you can break up the learning if you wish. In the first section, I'll introduce you to the MRC framework for complex interventions and talk through how theory of change is a real complement to this framework to enable you to design and, most importantly, to evaluate a complex intervention. I'm then going to talk you through how you develop a theory of change, what one is, and how you become a theory of change champion for your project. The second section of the talk is how you then take your theory of change and how you refine it to become the final theory of change, the final intervention which you take forward for your formal evaluation. And the third section of this course is how you use theory of change for the evaluation of complex interventions. Throughout the whole of the programme, there will be opportunities for exercises for you to do, and I'll pause and you can pause the recording and do the exercises, and then we can continue with the session. So part one, the MRC framework for complex interventions. So the MRC framework is a framework for the steps you should take, the methods you should use to design, to refine and pilot and to test a complex intervention. A complex intervention has many different active ingredients and combines those different ingredients in a whole that's more than the sum of its parts. So, for example, something which seems quite simple, like a vaccination, is actually a very complex intervention when delivered within a health system. You have to have the cold supply chain for the vaccination. You have to ensure that people are adequately trained in order to deliver the vaccination, and you have to make sure that the people actually come to the clinic to get the vaccination. So that's an example of a complex intervention, and actually pretty much every healthcare intervention is complex. So the MRC framework has 4 stages which take you through how you can design and develop a complex intervention, how you test that intervention and refine it through a feasibility and piloting process, how you evaluate whether the intervention works, and then finally what you do with the results of that implementation, of that evaluation, so implementing it in the real world. And this is a great framework for use, but it has problems, particularly when you are trying to develop and evaluate complex interventions in low resource settings, and particularly when you're looking at health services research or complex health interventions. The reason why the MRC framework is problematic is that it's not explicitly theory driven. So there's no underlying theories which capture the complex pathways through which capture complex pathways through which an intervention has an effect. Secondly, the MRC framework is very medical in its focus, and often complex interventions include psychological and social interventions. It's very patient focused as opposed to looking at the whole health system, which many complex interventions do. And it assumes that you are in a setting where you have well-resourced research staff, that you have control over the setting, that there's a high capacity for research. So all of these issues mean that the MRC framework needs to be strengthened in order to be truly useful for evaluating complex interventions in low and middle income countries in particular. So the solution to strengthening the MRC framework is a thing called theory of change. So this little cartoon describes why you need to, why theory of change is a really valuable addition to the MRC framework. So the idea is that you have all these complex pathways of what you want to do, and then you don't really understand why your outcome happens. Basically, you have a black box in which some form of miracle occurs. And the idea of theory of change is to unpack that black box, to understand the causal pathways through which an intervention has an effect. So all theory of change is really is a causal pathway which is empirically tested. Now, if you combine theory of change, this diagram at the top is an example of a real theory of change, and if you add that causal pathway onto the MRC framework for complex interventions, you end up with a theory-driven approach to the development, evaluation and implementation of complex interventions. And this should enable you to tell not just whether an intervention works, but also why it works and how it works. So to give you a really nuanced evaluation. So that's just a little bit of background as to the framework through which you would develop and evaluate a complex intervention, the MRC framework, and how theory of change can help strengthen it. So now I want to really focus on what theory of change is and how you can use it in your project. So, as I said, theory of change is a causal pathway which is empirically tested. It was initially developed to kind of a broad use in the 1980s by the Aspen Institute in the United States of America, and they particularly used it for complex community initiatives. They used it to develop and evaluate initiatives at a community level. It hasn't until recently really been used in research very much, but many donors and NGOs are realising the value of theory of change, and many of them now request their grantees or the people that get money from them to produce theory of changes for their projects and for their interventions. So it's used by NGOs to map out organisational change, to develop programme plans, to monitor and evaluate their programmes. It's used by donor agencies to demonstrate impact, and it's also increasingly used in complex intervention research. And certainly I've been using it for various projects which are evaluating and developing complex interventions, both non-randomised evaluations and also randomised evaluations. So theory of change is similar to other project management techniques such as logical models, log frames, project cycle management, driver diagrams. They're all part of the same family of tools which can be used to plan and evaluate a project. However, it has many advantages over these other frameworks. So the first one is that theory of change is generated through stakeholder consensus. So you develop the causal pathway map for your project through a workshop process whereby your stakeholders have a key role in deciding what to do and how to do it, and that generates a lot of buy-in. And later on I'll take you through the process of how that workshop works. Secondly, theory of change is really embedded in the context because it's generated through stakeholder buy-in, and because the theory of change map would be specific to each context in which you work. It enables you to show how the context affects your intervention. Thirdly, it acknowledges the complexity of change. So models such as a logical model or logic model work in a linear fashion from inputs, process, outputs and outcomes. There's no true reflection of the real pathway through which the intervention has an effect. Equally, project cycle management is simply a cycle, so you can't have feedback loops, for example, and a log frame has no structure at all, no causal pathway in it at all. So theory of change is really fantastic in that your map can look exactly how the intervention actually is in the real world, so it can reflect the reality of how your intervention works in the real world, and you're not restricted by a particular structure. Fourthly, theory of change is evidence-based, and I'll take you through this in detail, but every stage of the causal pathway is evaluated through your evaluation plan. It also measures not just activity, such as a log frame, for example, how many people have you trained, but it measures change. So have those people that you've trained got the required skills in order to actually deliver the intervention effectively? And if they have, and only if they have, can you then move to the next stage of the causal pathway, which is that people would receive the correct intervention as intended and it would be effective. A log frame would just measure the number of people that you've trained, which doesn't tell you anything about whether the actual skills of those people are adequate to deliver the intervention. And then the other benefit is that theory of change, because it doesn't have any imposed pathways or any structure on it, it can represent change at many different levels. So it's not uncommon to have a theory of change to have a health systems level, like for example, the district health authority might have a whole series of activities at that level. There might be activities at the facility level and also at the community level. So again, the theory of change is really reflecting the reality of how your intervention works in the real world. And I'll give you some examples of that as we go on. So now I want to take you through an example of what a theory of change map actually looks like and the different components of a theory of change map. Now these components, this example I'm going to give you is a very simple example, and it's purely for teaching purposes so that you really get a good understanding of the different components of a theory of change map. So when you're creating a theory of change, the first thing to do is to start with the thing that you're trying to achieve in the real world, and this is called your impact. So in this case, I've decided that I would really like to make my friends happy. That's the thing I want to do. It might be that you want to reduce the prevalence of malaria, or it might be that you want to improve depression symptoms. So whatever your thing in the real world you want to change. And then once you've agreed that, what your impact is going to be, you start a process of working through the steps that you would need to do to achieve that impact without having any preconceived ideas of what your actual intervention might be. So in this case, my happy friends, there are lots of different ways that you could make your friends happy. You could throw a party, you could buy them a present, you could send them a text, lots of different things. So the first kind of stage of it is to understand which type of intervention is most likely to have an impact in your context. So my context is that I really enjoy cooking, and so I would like to hold a dinner party for my friends, and previous evidence suggests that good food makes people happy. So there's a kind of underlying evidence for why I would choose that particular intervention in this context. So you then start building up the causal pathway, the theory of change map. You start with the things that you need to have to start. So if I'm going to have a dinner party, I need money to buy food and I need friends to invite. And if I don't have those two things, then the causal pathway ends there. I can go no further. And these are called intermediate outcomes. The next thing that happens is that you have to do something to those intermediate outcomes. You have to do interventions. So if you have money to buy food, I then go shopping. I do an intervention to go shopping and I send invites to my friends. And that causes new outcomes to happen. So we're moving up the causal pathway. So I now have food available to be cooked and my friends have accepted the invites to my party. And you keep on building up. So the next intervention is to cook the food and for my friends to travel to the party. So you can see that those interventions, there's already 4 different intervention components on the map. And the value of this is that instead of having one big complex intervention, which is in a big black box, you understand which intervention component is acting on which part of the pathway, so that when you evaluate that pathway, you can say which components of the intervention were the most important and where did the pathway fall down. So the next component of a theory of change map is assumptions. So at certain stages in the pathway, you're making assumptions, which if they're not true, you can't move forward through the pathway. So this particular assumption is that I can cook. I might have food and I might cook it, but if I can't cook, then the food will be horrible and my friends won't be happy. Now, what you would do is test this assumption, for example, through formative research, and if it turns out to be true, that actually I'm not a very good cook, then you might need to add in another intervention component. So, for example, I might go on a cookery course, or I might bring in a friend to help me cook, in order to make sure that the outcome of having nice food that's eaten does happen. So, assuming that I can cook, I've cooked the food, my friends have arrived, there hasn't been, another assumption might be that there's heavy traffic or that my friend's car breaks down and then they can't get to the party. If all of those things happen, then dinner is eaten. And after dinner, I'm hoping that my friends will be happy. And that is my long-term outcome. My friends are happy after dinner. And this is like the primary outcome of your trial or the primary outcome of your evaluation. Now, I understand that we need to have evidence. Sorry, the whole point of theory of change is that every link in the pathway has evidence on it. So the next component is the rationale. So the reason why we think that if you eat dinner, a good dinner that's well cooked, your friends will be happy, is that good food makes people happy. And there might be systematic review evidence which shows that your intervention works in other settings. There might be anecdotal evidence that shows that. And the point is that you build up the rationale for each stage in the pathway so that you have a good reason to think that this pathway will work. Now, in terms of achieving the ultimate impact of having happy friends, it's very clear that being happy is not just the result of what you had for dinner, if only it was that simple. Work stress, relationship problems, money worries, etc., etc., all contribute to whether my friends are happy or not. So you add in this wonderful magic line called the ceiling of accountability. And this ceiling says that we are going to be accountable for everything below the line, and everything above the line is what we're hoping to help contribute towards, but which we are not solely responsible for achieving through our complex intervention. So in this case, we could be accountable for making our friends happy after dinner, because that is a consequence of how nice the party was effectively, but we will not be ultimately responsible for whether they are generally happy. So now you get to the stage where you evaluate this pathway. So you finish the pathway. This is the description essentially of the intervention of your program that you're implementing, and then you add for every stage in the pathway, you add an indicator, and this indicator tells you how you're going to measure the pathway, whether that indicator had been achieved. So for example, whether my friends are happy after dinner, I might administer a well-being scale before dinner and after dinner and look at the change in well-being. To know whether dinner has been eaten, I might weigh the leftovers and decide that, say 80% eaten is a successful dinner eaten. So you set targets for what you want to achieve. Okay. So that is the summary of what a theory of change map is and its different components. I'm now going to take you through a real theory of change, and some of this is a bit practical, so I'm going to pause at some stages and ask you to think about what the next step in the pathway would be. So just to give you a quick background to this real theory of change that I'm going to take you through, it's from the Thinking Healthy Peer program, and it's a randomized control being conducted in Goa. And the problem it's trying to address is effectively, how do you reduce the burden of depression in mothers in South Asia when there is limited capacity in the primary healthcare level to address their needs? There's essentially almost no mental health services, but a very high burden of depression. So that's the problem we're trying to solve, and the impact we're trying to have is to reduce the burden of depression in South Asia. So we're working in a rural state of Goa, and our priority population is mothers who've got maternal depression, and we're also interested in having a positive effect on their children. And a variety of barriers which affect the kind of intervention that we could put in. So this is the context in which we're trying to develop and evaluate an intervention or a program. Low numbers of trained health workers. There's a very low level of knowledge in the community about depression. There's a very low level of health-seeking behaviour for mental health problems. There's stigma around seeking help, and there's limited time and money to travel to what facilities there are available which provide mental health treatment. So bearing in mind that context and the impact that we're trying to achieve, there's a variety of different approaches that we could use, a variety of different interventions that we could choose between, and this is the kind of decisions that you make in your Theory of Change workshop. So one of the potential approaches is to use task shifting, to use non-specialists, because there simply aren't any mental health specialists in the community. And a particular type of non-specialist we could use is community-based volunteer peer counsellors. So using effectively other women from the community of high standing and training them to be peer counsellors to provide psychological support to women with depression. And the type of psychological support they could provide is cognitive behavioural therapy, for which there is a huge amount of randomised control evidence that it works. We just don't know whether it can be delivered by peer workers in rural India. And also appreciating we need to raise community awareness so that people come and receive the intervention. And then we need to find the women from antenatal clinics in order to identify women with maternal depression, postnatal depression, so that we can put them into the treatment programme. So this is the kind of context within which we can build up our theory of change map. And the Thinking Healthy programme of these different approaches, they decided to use task shifting to community-based peer volunteers who would provide cognitive behavioural therapy to mothers with depression. So just to remind you of the different components of a theory of change map, we have a causal pathway which shows the causal relationship between the intermediate outcomes leading to long-term outcomes and the ultimate impact. The interventions are used to bring about each of the outcomes on the pathway. The rationale explains the logic behind each link in the pathway. Assumptions state the limits or the things that have the barriers that have to be overcome in order to move up through the causal chain. And indicators are used to evaluate the whole of the programme, the whole of the theory of change, and they must be specific enough to measure success. So let's build up this theory of change then for the Thinking Healthy programme in Goa. So the first thing to decide is what is our impact, and I want you to pause and maybe go back a couple of slides just to think if you can write down what the impact is we're trying to achieve with this problem. So hopefully you've had a think about what the impact is, and hopefully you've come up with something similar, which is a reduction in the treatment gap for maternal depression. So if you remember back to the context, there's very little treatment and there's a very high burden. So reducing the burden of depression, reducing the treatment gap is the impact for this particular project. So now we can work back through the causal pathway. So now we have to think about what are the primary outcomes that we are trying to achieve with this programme. What's the thing we're trying to change, and what are the secondary outcomes? So what are the other outcomes that might change as a result of this programme? So if you pause the recording now and have a think about what the primary and secondary outcomes are. So here are some suggestions for what you could have written. So the primary outcome, we want to improve the clinical outcomes for mothers with depression. So essentially reduce symptoms of depression for mothers who are treated by the programme. And the secondary outcomes might be improved social functioning, reduced disability for the mother, and it also might be improved child health outcomes such as adequate breastfeeding or improvement in infant weight in their children. You might also have written things such as reduced economic burden on the family or reduced caregiver burden. There's a whole range of different secondary outcomes that would be valid for this project. So in order to, going back one more step in the pathway, think about what would be the thing that would need to happen in order to make those outcomes actually happen in the real world. So again, I'll pause the programme and think about the next step in the causal pathway. So in order for the primary and secondary outcomes to be achieved, what needs to happen is that the intervention, the programme, needs to be delivered in the right way, essentially. So the mothers who've got depression must receive counselling as intended for the required duration. So they receive the intervention, they're adherent to the intervention, and if that happens, then it's much more likely that their outcomes will improve. We can carry on building up the causal pathway. So in order for mothers to receive counselling as intended for the required duration, the peer support workers, the PSWs for short, they need to have the skills to deliver the counselling, to appropriately refer mothers who are too severely depressed to be treated by them and need specialist care, and they need to be able to conduct community awareness raising. And they are the components of the Thinking Healthy programme, peer delivery, the THPP programme. In order for the peer support workers to be able to deliver counselling and have all these skills, they need to be situated within a health system which supports them. So the step before that in the pathway is for the peer support workers to be in post and integrated into the health system. And then you need to add in another intervention, the stars of the intervention. So once you have the peer support workers in post, you then train them to give them the skills to deliver counselling, etc. You can see how the pathway is building up. And if you look across the pathway, you can see kind of vertical phases of the programme almost. So the resources you need to put into the programme, identifying women, the treatment they receive, the outcomes you achieve, and the ultimate impact you're working towards. So if we carry on filling in this pathway, the community health work, in order for the peer support workers to be in post, the stage before that is that community health workers have to identify peer support workers, they have to recruit them into the project, and they have to supervise them. And they also need to conduct community awareness raising. So think for a minute what needs to happen in order for the community health workers to do that bit of their job. So the answer is that one of the answers, there's no right answer in theory of change, is that the community health workers need to be aware of the programme. And in order for them to be aware of the programme, in order for them to have the skills, in order to train and identify and recruit peer support workers, they themselves need to be trained. So it's another intervention component. Adding in more interventions, those community health workers supervise the peer support workers. So that's just one pathway for this intervention that I've taken you through to show how you map out the causal pathway and add in interventions to make each stage in the causal pathway happen. Now we can build up the rest of the picture of the theory of change. I'm not going to take you through this in detail, it's really just so you can see what a full theory of change might look like. So essentially the blue boxes I've just added are showing that within the antenatal clinics people are supervising peer support workers, are identifying mothers with depression using screening tools, and those people need to be trained, and then they screen the women to find out who's got depression and refer them either to specialist services for people who've got severe depression or who have psychosis or suicide as well, so it's suicidal risk, or if they pose no risk and they have mild or moderate depression, then they can get referred into the peer support worker counselling programme. And here we get some feedback loops whereby those women who don't recover get sent for specialist treatment, and those who are recovering from specialist treatment get returned to the community for supportive counselling. So you can see when I say that theory of change has no structure imposed on it, you can see here that that's true. You can have little loops going on, you can have arrows going in different directions. It's meant to reflect the reality of how your programme actually works in real life. So adding the ceiling of accountability to show that while we're working towards an impact, this project won't actually on its own reduce the treatment gap for maternal depression in the district. It'll only have an impact on improving the outcomes of the women who are actually treated by the programme. So all of these things in this bracket are the intermediate outcomes, and then the primary and secondary outcomes are the long-term outcomes of the project, which you can think of as the primary outcomes of your evaluation. So carrying on building up the pathway a bit more, we've got now supervision added in. An intervention coordinator is going to supervise. They obviously need to be trained, and then they use that training to supervise the other staff involved in the programme. And then we've got this whole missing thing where we actually need the community to be aware of peer counselling and mothers willing to seek help and receive treatment from peer support workers. So in order to do that, we add this extra intervention component, which is awareness raising, whereby everybody involved in the programme is involved in raising awareness in the community that this programme exists, that people should not be stigmatised to seek help through it. And if that happens, you get the feedback whereby the mothers in the community are happy to receive counselling as intended and for the required duration here. So the next component to add to this map, that's the full pathway of all the outcomes and the intervention components. So now we need to add the rationale. So we need to consider the existing evidence, which is the reason why we think moving from one stage of the pathway to the next is possible. So firstly, the rationale is that there was an existing trial in Pakistan of the Thinking Healthy programme delivered by community health workers, and it was very effective. So there's a strong rationale for why we think non-specialists can deliver effective counselling, but now we need to test whether it works in India and also whether it works with peer support workers as opposed to health workers. We then need to add assumptions. So there's lots of assumptions on this pathway. For example, the whole programme is based on the premise that women exist in the community who want to be peer support workers and who have the qualities to be good peer support workers. If those women don't exist, or if they don't have the right qualities, or if they exist but they don't want to volunteer, then there will be no peer support workers in the programme. Equally, mothers have to be willing to receive counselling from their peers. And this is actually quite a major assumption, because you might not want to tell your deepest, darkest secrets and your emotions to somebody who is another woman from your community. So these are all important assumptions at the beginning of a project which you need to test in order to check whether your programme will work or not. So you elicit all the underlying assumptions across your pathway. Then the last stage is to add the indicators so that you can then develop your evaluation plan. So firstly, for the primary outcomes, we might, for example, look for a 50% improvement in depressive symptoms and in social functioning 3 months after enrolment in the programme, for example. Or another indicator further down the pathway, which would be seen as a process indicator, would be that we've recruited 8 peer support workers to the programme. So we've worked out how many women we need to have in our evaluation, and then we can work back from that to work out how many women each peer support worker can support. And as a result, we've worked out we need to train in total, we need to recruit 8 peer support workers. And that's our target for recruitment. Actually, we only need 6, but we're recruiting extra because we know that there'll be attrition, and we know that we want to only retain those peer support workers that show that they have the right skills after training. Another indicator might be that 80% of women who attend the antenatal clinics are screened. If a lower proportion than that are screened, then perhaps we're going to miss lots of women with depression, and it's quite plausible that the screening will systematically miss the most at risk of depression. And also then the 80% of those who are diagnosed with depression are appropriately referred. So you're not getting too much dropout at each stage in the causal pathway. So you might measure those indicators through looking at the routine records of the antenatal clinics, for example, as part of your evaluation plan. So you put an indicator for every single stage in the causal pathway. And then once you've done that, you gain approval for the draft theory of change from stakeholders. And then that would be your theory of change. Excellent. Now the next section I'm going to talk about is how you become a theory of change champion for your project. So the actual kind of process through which you develop this map within your project team. So I've talked about this theory of change workshop, so I'm just going to take you through a little more detail of how you would run that theory of change workshop. So as I said, it's a participatory planning process whereby you would bring together all of the key stakeholders for your project. So that might be local policymakers, it might be physicians, it might be community health workers, it should be service users and their carers. And you really want to bring in a wide range of stakeholders, everybody who's involved in delivering and receiving the programme. Depending on the context, you might change who exactly comes to the workshop. So, for example, if it's not appropriate to have the district health officer in a workshop with carers or service users, then you might have separate workshops for those people, because you want people to be able to speak freely. So really, how you run your theory of change workshop is completely up to you in terms of who you have and how long it lasts, and the constitution of who you have, and it should really be whatever is appropriate for the context you're working in. The key things are that you draw on diverse knowledge. So you don't just say the only rationales that matter are from, peer-reviewed journals and from trials. You should. Everybody's knowledge is valuable. If a community health worker believes that something wouldn't work in practice, then that is, as good evidence as somebody saying a paper in the Lancet said that this wouldn't work. And that's the way that you build something which is locally more contextually relevant and hopefully more effective locally. You do need a facilitator who knows about theory of change and who runs the workshop. Now that facilitator should really be the person within the project who is your theory of change champion. So the person whose responsibility it is to develop the theory of change, to see it through the whole process of the project. Everyone else in the workshop does not need to be trained in theory of change. They don't need to know what an indicator is, what an assumption is, what an outcome is. They just need to be there to contribute their ideas and their suggestions. And the facilitator puts all of that up on the wall, basically using post-it notes. So you would have a different colour post-it note for an outcome, for an indicator, for an assumption, etc. And you can build up in a very organic way the pathway that you want to that you create. So I've said some of this already, but the key facilitation skills are really that they understand theory of change, that they are clear, they're organised, and they're focused, and they're fair, and that they ask for everybody's opinions and they don't let one or two people dominate, because obviously if they did that it wouldn't be a participatory process. The challenges of running these workshops are sometimes it's hard to get stakeholder buy-in. That's true of any kind of participatory process. Sometimes there are difficult group dynamics or politics going on, which the more you're aware of in advance and the more you can manage, the better. We've had problems sometimes with the group expectations have been huge. So when you say what impact do you want to achieve, they'll say, oh, we want to, cure HIV, for example, which obviously isn't a realistic expectation. So managing those expectations and enabling people to be realistic about what they can achieve in the context with the given resources can sometimes be challenging. If you do have multiple workshops, because for example your stakeholders, you need to separate out your stakeholders into different groups, then how you handle that can be a challenge. The thing that we would suggest is to first of all have a high level workshop with your policy planners, your clinicians, and then they would be the people that kind of outline the structure of the intervention, and then you would present that structure to a workshop with perhaps community health workers and service users and carers in it to get their feedback on whether they think it would work, which bits of the pathway are problematic, if we missed anything, what things could be added, etc. And the last challenge is obviously everybody is very busy. Getting multiple people together for a number of hours is always challenging. We found a good kind of amount of time is to have, say, a morning where you would develop the initial theory of change, and then you might go away, type it up nicely, and have another workshop a few days later where you reflect, you get the group to reflect and modify and finalise the pathway and add the indicators and the assumptions and the rationale. In total, you're looking at really about a day of people's time, which could be split up and however is appropriate for the context. And in terms of follow-up then, so you've developed your theory of change, you've got a map, you might also want a narrative summary to describe the map, and then you take that theory of change throughout your whole project. You can refine and test the intervention, and as a result refine and test the theory of change, and then you take it to the final, the kind of formal evaluation. It might be a trial, it might be a non-randomized evaluation. And then at the end of your evaluation, you would review the theory of change and redraw it to reflect the reality of what you actually found, so that your final theory of change is essentially a description of your program and how it worked in reality in that setting. Now, the last section of this this bit about what theory of change is and how you construct one is just a little revision quiz. So I want you to spend 5 minutes or so and just join the dots. So the theory of change components are on the left-hand side, and on the right-hand side is a description of what those things are. So to give you an example, number 1 matches to G. So the reduction of the treatment gap for mental health problems in Nigeria is an impact statement. So I want you to look at number 2, a long-term outcome, and decide which of the statements on the right-hand side matches to a long-term outcome or an intermediate outcome, intervention, etc. So if you pause for a few minutes and complete that exercise, then I'll come back with the answers in a few minutes. Great, so here's the solutions. So the long-term outcome matched with statement D. So the long-term outcome, improved mental health outcomes for people with mental disorders treated in district hospitals. So that suggests that it's something measurable and achievable, that project could actually be accountable for achieving. An intermediate outcome might be that there's adequate ongoing management, quality control and supportive supervision in place by the district hospital. An intervention is statement A, so a psychiatrist from the Federal Hospital provides supportive supervision and runs outreach clinics. So that's an intervention, it's a thing to do, a thing that is done, intervention component. Assumption is statement B, so the district hospital staff are willing to treat people with mental health assumptions. This is an assumption that has to be true for the pathway to work. Oh, sorry. So those arrows are missing. So for number 5, the rationale would match to E. So systematic reviews in low and middle income countries identify task sharing as effective is a rationale for the pathway. And finally, an indicator, number 7, would be statement C. 80% of patients with mental health problems are treated in the district hospital. So that's an example of an indicator which you can test as part of your evaluation plan. So that concludes the section on how to develop a theory of change. And the next section, the next recording, will be on how you use a theory of change to refine and pilot test and evaluate an intervention in order to take it forward for your final evaluation. Thank you for listening.